Hello, and welcome to today's webinar, Beyond Telehealth, Fundamentally Reimagining Healthcare Delivery. My name is Ashley Barrison, and I'm a marketing manager for Livongo. We are so excited to partner with Oliver Wyman on today's webinar and would like to extend a warm welcome to today's presenter, Sam Glick. Sam is a partner in Oliver Wyman's Health and Life Sciences practice and also serves as the director of the Oliver Wyman Health Innovation Center Leaders Alliance. In his role, Sam works collaboratively with senior executive teams across a variety of industries, from providers and health plans to employers and retailers, to help his clients create innovative solutions that provide delightful, affordable, high-quality care coverage and financing to consumers. Also joining us today is Livongo's founder and executive chairman, Glen Tullman. He founded Livongo with the mission to empower people with chronic conditions to live better and healthier lives, with a focus on diabetes, hypertension, weight management, diabetes prevention, and behavioral health. Glen is dedicated to finding a cure for diabetes and other chronic conditions and to keeping people healthy until those cures are found. Before he founded Livongo's consumer-first digital health platform, he was the CEO of both Allscripts and Enterprise Systems, both companies he took public in his drive to change the way healthcare is delivered. Finally, we're doing something a little different for this Summer Friday webinar. We're excited to welcome Elizabeth Baer, a talented visual artist who will be sketching the concepts that Glen and Sam discussed today to bring them to life. We're excited to share her work with our registrants after today's event as well. Before we jump in, I have a few additional housekeeping notes. While CE credits are not available as part of this webinar, everyone who registered will receive a recording of today's discussion. We also invite you to ask questions at any time during the presentation by typing your question in the Q&A box. Our experts will tackle your questions as we wind down today's presentation. All right, I think we're ready to get started. Glen and Sam, to get you started, our first question is, do you see telehealth and remote monitoring usage increasing after the current pandemic? And to what extent can virtual health be leveraged for care management beyond remote monitoring?
Thanks, Ashley. And maybe I'll get us started, and then Glen, we can have a conversation. It's great to be here today and have the chance to have a chat, even though there's not much of a fire here as we kick off the summer. In short, I think, yes. We know from years of research that we've done at Oliver Wyman, the surest way to get somebody to become a regular telehealth user is to get them to try it once. That hurdle of trying it once is the thing that gets people excited by it. Interestingly, our research shows that when people try a doctor's appointment, an in-person doctor's appointment for the first time, they're actually less likely to go back to the doctor. They're more likely to go back to telehealth when they try it. And we have seen just a staggering increase in telehealth utilization as a result of the COVID pandemic. And I'm sure we've all seen numbers in the news, but one of the ones that sticks with me is if you look across all Medicare members, all Medicare claims, and these may not be the people we would picture being kind of early adopters of telehealth. Typically before the pandemic, CMS saw about 11,000 video visits a week for Medicare members. In April, they saw 1.3 million video visits a week. Just an incredible increase in the Medicare population. You think about the commercial population, you think about those on Medicaid, you think about those paying cash, you expand that. One of the things I hope, and Glen, this has been your life's work in many ways, is that getting people comfortable with these video visits, making this the norm, is just the first step on the journey to people really having a different kind of relationship with the healthcare system. I have a colleague who was in banking who says that if healthcare had invented online banking, we'd just be talking on a screen to a teller as opposed to doing something fundamentally different. And places like Livongo really are doing something fundamentally different. And remote monitoring, we were debating before this session, it kind of has an old system connotation. It's this idea that you are remote from the system, right? The system is still around healthcare that is somewhere else, as opposed to around the person, right? Healthcare isn't remote to me when it's me. I am the hub of the healthcare. And monitoring implies that it's something somebody else is doing to me. right? They are watching me. I'm watching you from afar as opposed to I am engaged with you in your health. And thinking about my own healthcare experiences, I've thought a lot about the healthcare system, not necessarily intentionally, but I think in its design creates a kind of helplessness that, I go in, I talk to the doctor, I don't know what's wrong, I get a test, I hope and I hold my breath and I come back and I find out what the test does. And then I go home and I do things for a few months, hopefully. And then I get another test and then I go back to the doctor and I hold my breath and I see how I'm doing. And there's this kind of information asymmetry. And I think the real power of telehealth is to say we can change that from kind of being a system that creates helplessness to being a system that creates empowerment. That remote monitoring is really digital empowerment. Remote monitoring says, I can have the information I need 24/7 about my health. I can then have guidance about how to interpret that information. And sure, when I need to talk to somebody or I'm in a tough situation, they'll reach out and talk to me, but I don't have to worry about, am I going to go to my appointment in 4 weeks, whether that's on video or in person. That it's empowering me to be at peace with my health, to take charge of my health, and to use the kind of information and understand that kind of information that I can then have a more productive relationship with the people in the system. So, Glenn, I suspect I'm preaching to the choir here, but I'm curious what you think.
Well, first of all, thanks, Sam. And it's always great to be with you, to talk with you, to learn from you. And I heard that whole long introduction, and I said, look, to me, Sam's just the idea guy and the visionary who can hopefully share with us where healthcare is going, and that way I can follow. So that's a lot of the reason we spend time with Oliver Wyman, to help us figure out not where we are, but where we're going. And Ashley asked a question, and you talked a lot about first names. And I always say, if you want to change the world, you have to change the words. And right now, our words aren't exactly right yet. So your analogy of the ATM was a perfect one, which is, in a sense, telehealth today is just, we've taken the old process. You go, you drive to your physician's office, you see her, or you see him, and then you drive home. And now we've made it simpler, but it's still spending 15 minutes or 10 minutes directly with a person. And that's hard to scale. So if we wanted to provide that same level of quality to everyone in the world, we'd very quickly run out of physicians. So that's not really the best use of technology. Again, I use the analogy of, you took a horse and buggy, you went to a car, but it's still getting from point A to point B on a road. And the difference is, if you could fly in a jet, you'd be a lot better off and you'd get there a lot faster. So what we want to figure out, and one of Sam's tasks, and he didn't tell you this, was to create new names for us to use. So this idea of digital empowerment, I think he was teasing us with that idea, but we think of, if you love telehealth, and we all love telehealth, then you're going to really love remote monitoring. And that is because telehealth takes what we're doing, it makes it easier, simpler, it's safer, particularly for our physicians. If you think you have COVID and you go and see your physician, that's a pretty dangerous interaction for your physician. Better you have a telehealth visit and then you figure it out. And then if they believe you have it after the right kind of testing, you can go to the right appropriate place. Well, remote monitoring, or whatever it should be called, is the next step to allowing us to deliver scalable healthcare. First, it meets the requirements Sam talked about, and that is, it's 24/7. It meets you wherever you are, and you're in charge. And this idea of empowerment. Livongo, from day one, we talked about empowering, not engaging, not getting you interested, but empowering you, giving you the power, empowering people. It wasn't patients, it was people just like you and I, empowering people to live better and healthier lives. And so it wasn't about healthcare. It was about, how do we give you the tools, put you in charge to control that. And remote monitoring, not only does it allow you to do it, but essentially it's providing you the information. So rather than doing an annual checkup, you might get a call in the future that says, great news, you don't need an annual checkup because we're monitoring you. and we can tell you're doing great. So whatever you're doing, keep doing it. We'll save you the time of a checkup. Someone else might take the slot you would have used, and they actually need care. And there we can optimize the use of our physicians and optimize the patient's time as well, or the person's time as well. So I think when you look at that, we're starting to see this first step. And Ashley's question was about what's going to happen post-COVID. And I think we've given everyone a taste of this new digital world. And from my conversations, including one as recently as this morning, we're seeing what used to be telehealth at 3 to 5% industry-wide. It went up to all the way to essentially 100% because there were no more visits during the initial stages of COVID. And then it settled in at 85-ish%. And most systems, and Sam, it'd be interesting to hear what you're hearing, but most systems are telling me that they think they're going to end up between 35 and 50%, essentially shifting about 10 times what it is today and shifting that. But moreover, I think we also showed the healthcare system how quickly things could get done. So I've had a number of different healthcare leaders say to me, we've been trying for years, and in a week, we had everything we wanted to get done in our 5-year plan done. And so hopefully in the future, it doesn't take a pandemic to allow us to continue on that pace. But we've seen it in trying to develop some of the new drug therapies that we're trying to use. We've seen it in terms of all kinds of adoption across every sector of our economy. You know, we've seen it, of course, first and foremost on the education front. We had to figure out how to deliver education. In some cases, people have said it's better than ever. In other cases, it was a disaster. And that's what change is. We figured out how to get most of the population comfortable with commerce, digital commerce. And a lot of those folks won't go back. You know, somebody said to me, the idea that I used to cart all these heavy bags of water bottles and dog food, and now they can be delivered to my door, why would I ever do that again? So that's commerce, and that's education. And now, of course, we're talking about healthcare. So I think we're seeing this rapid shift. I don't think we're going to go backwards, but I really believe the goal, and Sam, you and Oliver Wyman, your firm, have to help us make sure that we're not just automating the old way, that we're actually using the technology to rethink these interactions. So, you know, that's the way we're approaching this at Livongo. And in a time when so many people are challenged, it's a little awkward to see our business expanding so quickly. On the other hand, we think it's for all the right reasons. Sam?
Yeah, no, it's a good point. And your point about how we saw this rapid acceleration, not just in telehealth, but in a lot of things in the last couple of months, I think is a good reminder for all of us. A lot of times, you know, myself included, but I talk to people who've been in healthcare longer than I have even, and they say, well, you know, we all know about the promise of telehealth, but well, CMS has been paying for it for 20 years and it's hovered south of 10% for that whole time, right? And there's this kind of mental bias that if you're not seeing linear change in something, it must not actually be that big a deal. And instead, if we, you know, hindsight is 20/20, I think if we look back, we said, no, all the conditions were right for telehealth. All we needed was one more trigger. And this pandemic happened to be that trigger, because the reimbursement, we knew how to do it, and then CMS flipped the switch in the right way. The technology, we now have broadband and mobile broadband in a lot more places than we ever did before. People are comfortable with video and technology. We've got a phone in nearly every pocket or purse. We were ready, right? And it triggered. And I think as we think about other innovations moving forward, Glenn, to your point, we should always check our biases and say, are we just having a bias because we haven't seen linear progression? Or are we really looking at, are the conditions right? Can we be ready? And then I actually think for a lot of big health systems, can we accelerate it? And that was actually one of the challenges of telehealth. And it's one of the hard conversations to have, that the fact that many big systems could do what they did inside of 2 months, and I know a lot of them, that went from, you could count on one or two hands the number of visits they were doing a day to thousands a day that they were doing, was not a technology issue. It was sitting there on the desktop for a long time. It certainly wasn't a consumer engagement issue. They figured it out quickly. It was a workflow issue, an operational issue, an issue of getting physicians.
And a payment issue.
And a payment issue. And a payment issue, and getting paid for it. But sometimes we look at it like it's a tech issue, and it's actually a lot of those other things. I also think, and Glenn, I'd be curious where you think sort of beyond diabetes, and I know you've gotten into a few new areas recently that I'd love to hear about. Fundamentally, telehealth, or this idea of digital empowerment, I think changes the practice of medicine. It changes it in kind of simple lifestyle ways. I have talked to physicians who have now said to me, wow, I never thought of being a physician as a work from home job. I might be able to stay in the workforce longer. I might be able to do this part-time when I have kids. Women who said I might be able to stay a physician or would consider being a physician differently. But beyond that, medicine today is largely snapshot medicine. Even when you go in for an old-fashioned, kind of physical visit, it's one set of tests, it's one conversation, it's 7 to 10 minutes, and then somebody's having to make a lot of decisions based on relatively little data, based on a snapshot. And to change the practice to say, that interaction may be a short period of time, but I'm now making a decision based on a continuous picture of your life and your health, I think really changes the kinds of things we think the health system could do.
Well, it does. And Sam, I think you make some really great points. Today we're space bounded. So, and there's actually a book behind me called Unscaled by Hemant Taneja.
Yeah.
It's really fascinating.
It's a great book.
Because he really talks about this idea is what we do when we make progress is we centralize things. And then when we make more progress, we decentralize them. So we had a mainframe computer, which was unbelievable. And now we have that same computing power at our homes. And thankfully we do, because that's where we're all working from. When you think about, we centralized healthcare, and we did it at large hospitals, one of the largest buildings in every town, the hospital. And now we're getting the sophistication to decentralize again. We centralized printing long ago.
Yep.
It was at the church, the biggest building in every, and then when the printing press came along, we democratized it. So the only way we're going to be able to deliver care in the future, the way we need it, at the scale we need it, is to use digital to allow us to provide scale. And it's pretty fascinating. I know there was a question, we'll probably get to it later, about what about some of the older people, how will they do digital? Well, I think one, that's always the challenge of, that means we have to make it not about the technology, but about the experience. But if you think about the largest reason that people don't get care, it turns out to be transportation.
Yeah.
The single largest reason, and access. So people in rural areas, they don't have an endocrinologist, they don't have a cancer specialist. So how do we deliver that care wherever they are in the world? Now, one answer is you get better transportation to cart them from their location to the hospital. And that really, in many respects, is untenable. And it's not very much fun. For a lot of these folks, you got to send virtually an ambulance to pick them up, take them to see someone for 5 minutes. It would be much better to give them a digital setup. And Sam also mentioned this peculiar notion that we go to see a physician and she or he orders lab tests for us, but they see us without any real data.
Yeah.
We wouldn't want anybody to make a big decision without data. What should happen is we ought to do a telehealth visit. Then they would recommend we get the appropriate labs or we do the appropriate monitoring. And when we finally see them in person for that valuable 5 or 10 minutes, they have all the data to use their judgment to make the best decision. So we've got to flip these models, and it's never about the technology. It really isn't. In fact, when we're talking about technology, it usually means it hasn't worked.
Yeah.
Because no one talks about the unique technology behind our cell phone, the chipset and the cell towers and the number of towers and the penetration and the signal strength. We just use it. That's when technology is best. And there's this wonderful quote, technology perfectly applied is indistinguishable from magic. So when things work, they just work. They're just there. As an example, at Livongo, when someone's blood sugar is dangerously low or dangerously high, we will call them within 60 seconds to check on them. And we don't say, can we help you? And Sam picked up on this. We say, what do you need? We're not there to help. We're there to provide a service. They're in charge. But when we do that, some of the people say, wow, you called at the perfect moment.
How'd you know?
How did you know? And they literally say that. If we smile, and it's like, well, because you were blinking in a red box right on my PC. And we had a whole bunch of people focused to say, is Sam okay right now? But for them, it was magical. Now, if we call them randomly in the middle of lunch, and we've all received these calls, or in the middle of our workday, then we're actually almost angry about the call. We don't see it as a helpful call. We see it as an interruption. So using technology to provide that magical experience is really where we want to get to. But it is all about rethinking that experience and starting over. And now we know we can. We've been given permission. So I think that's going to drive this next stage.
Well, I think that the point about seniors in particular, and this conversation comes up a lot. Well, which segment is telemedicine for, telehealth for, remote monitoring for? And I think we got to get out of that mindset that there are times when somebody who's 85 and homebound is going to be best served by something tele, and there are times when she needs to go to the doctor and we get a consultation, and there are times when I'm going to be more likely to walk into the place in the corner, and there are times when I need to do it on my phone. And we've got to start getting out of the mindset of whom are we targeting with this technology, and instead, which use are we targeting, right? Livongo works for diabetes because diabetes is a continuous problem, and continuous problems are well served by technology. I think a lot about, my mother who has been, who's vulnerable given her age, and she's been home during COVID. And in the course of COVID, she has started using Zoom. She goes to Bible study via Zoom on Wednesday evenings, right? Taught herself how to use it, downloaded it, worked pretty easily on the iPad that we gave her. I shipped her an Amazon Echo, and she gets all her music and podcasts and news off of that every day. Technology, the better it is, the more accessible it is. But she had a use case for it, right? She was inside and she needed to use it and she wanted to stay connected, and she's doing it. And I think we've got to switch this mindset of, healthcare has gone on this kind of slow evolution from, well, we're going to segment you by what kind of payer you are, to we're going to segment you or what kind of insurance you have. We're going to segment you now by, we think we're sophisticated, by what disease you have. And we need to start saying, we're not going to start segmenting people anymore. We're going to think about what are all the needs in their life and where can technology address those better. And everybody's got a different set of needs. I also think the same thing, Glenn, we get the reimbursement question a lot. I'm sure it'll pop up here. Reimbursement matters a ton, as you said. I think we have broken through that barrier with COVID. I would be surprised if we move back, given its popularity. But we got to put the burden back on ourselves a little bit. You get in this chicken or egg problem of, if you want reimbursement, it better be worth reimbursing for. And we're right now in a reimbursement parity kind of mentality. That's great, but if you're in a market where a primary care visit costs $200 or $300, that's just inaccessible, and you shouldn't charge that for a video visit. That's a transitionary way of getting it there, but you're not delivering $200 or $300 of value to somebody, and we got to start thinking that way.
Well, I think that's in part about what is the visit for, and certain visits, one, you've got to meet people where they are. So they will determine, we won't determine what's best for them. They should determine it.
Yeah.
And so this is about consumer first or consumer focused care. And the idea, and again, we have to separate this healthcare idea to health and care.
Yeah.
And they're two different things. So one, let's use this technology to keep people healthy, at home, and out of harm's way. And then let's take the people who need care and deliver world-class care. And we have to separate those two. I think sometimes we get confused. And then, there's no other place, like in this country, healthcare happens to us. And again, we want to get back to where we're in charge of the healthcare. And we see more and more of this working toward consumer-directed care. And I think the challenge of that is you have a lot of pieces of the healthcare ecosystem, and they want to determine the care. I mean, it's not so long ago that people said, you see your doctor between 8 and 5 as long as she is not at lunch. Now, the fact that many of us worked during those hours wasn't really taken into account. And if we think of health and care as service businesses, you wouldn't say, well, you can only eat at that restaurant between 8 and 5. It would go out of business. You wouldn't say, you would go out to an entertainment venue, but it's not open on weekends. That's not what we would do. So we're going to see the rapid consumerization of healthcare across the board. And either people will get on or others will start to say, here's what works for me. And they will vote with their feet. But this idea of information transparency, when you look, you're going to say, what does it cost to go here? What's the quality? And how convenient is it?
Yeah.
And what's the after level service? Can I actually talk to my physician or to another care professional, a nurse or the like? So that it's really about experience. And we've seen every other area of the economy redefined. Again, we talked about, long ago, you used to need an encyclopedia to look up information or go to a library. And then Google made it accessible to anyone in the world 24 hours a day for free. And then we used to have an issue in community. Well, you want to get together with your high school friends or with your family, and that was tough. And now we have Facebook, anywhere in the world, 24 hours a day, free. Then we went to commerce, and 24 hours a day, anywhere in the world, you're in charge, what you want to order, etc., from Amazon or others, and not free, but close. And then the last C, so you had content, you had community, you had commerce. That last C is care. And all you need to do is look at the rest of the economy. 24 hours a day, access to pure information, and by and large, in many cases, it's going to look like it's free. We already have some healthcare systems saying we will provide, especially for people with chronic conditions and others, we'll provide this care free. We'll provide mental health services free, because if you're lonely and you're at home and you don't take your meds and we've got to come and get you with an ambulance, that's a lot more expensive than taking care of you. So this idea of care 24/7, I think, is going to be very, very different.
So Glenn, I'm curious. There's you and I think are clearly both, big believers in the potential of telehealth and of this idea of digital empowerment. And but there is a certain amount of creative destruction in this kind of thing, and there are people who end up on the losing side of it. As you built Livongo, as you've now become, much bigger, and I think have hundreds of thousands of users, what resistance do you encounter?
Well, look, I think the biggest challenge in all of this is there's an existing ecosystem, and there are people our progress is someone else's loss. Let's talk about rebates. So there's an entire rebate system that made test strips for people with diabetes inordinately expensive. And lots of people were profiting from those rebates, which we would call in every other industry a kickback. Yep. And it should be illegal. And fortunately, we're making progress. But there's a whole bunch of people who accepted that as a way of doing business. We have a lot of those kinds of inequities in the healthcare system today. And those are going to be squeezed out of the system, but not without a fight. So we have to have proper reimbursement for our physicians. And as you mentioned, that's a give and take, because it may not be the exact cost that they're getting now. On the other hand, we should be able to reduce their expenses. But there's players in the industry that are going to fight this change. And we think at the end of the day who said it? I forget who said it, but in a fight between you and the world, bet on the world. The consumer will win this one. It's
Yep.
just a question of how long it takes her to do that. And we're going to see that fight. But there wasn't a part of the healthcare system, particularly the people who are providing the rebates, the strip manufacturers. The fact of the matter is they were preventing progress, to pad their own pocketbooks. And, people who are taking rebates today, this is not helpful to the members, to the individuals they're meant to serve, whether, across the board. They should not be accepting rebates, and that system needs to go away. And we've also seen this in areas like insulin, where the cost of insulin has been marked up 500% over the last 5 years, 500%. And that's all the middle of the equation. Very little of that actually was from the manufacturers. And it's all the middle of the equation where people are increasing prices and not allowing people to get insulin at reasonable prices. What happens when you do that enough, the government ends up stepping in. Yeah. And we ought to be able to police ourselves and not have the government have to step in, but they will, because people aren't going to take that relative to drugs or any other kinds of treatments. So we have to show our leadership by helping to push forward on these systems. And again, one of the few positives of the pandemic is hopefully enabling a lot of people to realize they could do healthcare in a different way. And we've seen some very innovative health systems and health plans and payers and PBMs all step up in new and different ways. We've seen other ones who went the other direction. They went back to the old models and they doubled down. And that's going to sort out the winners and the losers.
Yeah, it does. It makes me think about whether we really need to redefine value in healthcare, Glenn, because a lot of the things you list, right, the rebates and the markups and all these cross-subsidy economics, it's not. I think there are very few people. Of course, there are a few bad actors, but very few people who wake up in healthcare and think, well, how am I going to rip off my customer today, right? We've just normalized these things. It's not in a bunch of individual bad intent. It's normalizing this kind of mentality. And when we talk about value in healthcare and value-based care, it's largely a euphemism for how do I take cost out and then split the spoils with somebody else. And if you instead take a look at it from the consumer's view, the individual's view, and say, if they were fully exposed to the price and who was getting the margin, would they think they were getting value from those people? Would they think they were getting value from those individuals? You'd build a lot of things fundamentally differently. I mean, it's even when I think about health insurance and where the dollars go, we were doing some analysis. We all know the U.S. spends $3+ trillion on healthcare. The biggest chunk of that, nearly 40%, goes to hospitals. To your point, solutions like Livongo and everybody else focus on keeping people out of hospitals first, and then you do things on top of that. Consumers spend the majority of their dollars on drugs and physician visits. By the time they land in the hospital, somebody else is picking up the whole bill. So when they think about healthcare affordability, it's, can I afford to get my drug? And it is, can I afford to go to the doctor? And we see real behavioral changes. Rena Shaw from Walgreens was sharing with me that if the copay for a drug crosses $50, the rate of somebody picking it up drops by half. Right?
Yeah.
These are people who show up, they do the work, they get in the car, they go to the Walgreens, they say, how much is my prescription? And they say, sorry, can't do it. And if we took a value-based view in that and said, am I delivering enough value to this person through their lens, through what they can afford, I think you'd build a pretty different system.
Well, I think I agree with you largely. I'd say the one thing is we see, if you look at the number of bankruptcies in the country, the number one cause of bankruptcy is healthcare. And I think as the population ages, more and more people are getting, their knee, their hip, everybody knows somebody. I mean, the idea that 10 years ago, hip surgery was really rare. Yeah. And today, I can name a whole slew of people who have a new hip or two new hips. And so I think this is becoming more common as the population ages. And I think that the cost people are starting to get more sensitive to all of the costs, including things that we used to think were more exotic that now become more common. So I think you're going to see that. I absolutely agree. The sensitivity levels for healthcare and avoidance behavior are very high. And I'm surprised it's 50.
Yeah.
We see in a lot of areas where under-resourced people, are not picking up their meds when they're $20 copays. Because remember, that's a $20 copay for them. They may be on multiple medications, and then they have the rest of their family to worry about. So those $20 copays can add up quite quickly, and that's a real challenge. But I want to go back to something you said. I think all of our listeners are familiar with Haven.
Yeah.
Haven is the joint venture created by Berkshire Hathaway, Amazon, and JP Morgan Chase. And they created that, and Jeff Bezos said, we're creating this because we have lost trust in the large health plans, in the PBMs, and in the health systems, and their ability to have the same goals that we have. Okay, that's an unbelievable to think that three of what many would argue are some of the top and smartest companies in the United States, maybe in the world, have said we're going to have to create our own system because the current providers aren't aligned with our interest. And if you think about that, every one of those other providers, when the cost goes up, they make more money.
Yep.
And so that idea and the fact that they had that, the minute they did that, our phone rang off the hook to say, you have an alternative to Haven, because if you're another bank, you're not going to go into Haven.
Right.
It's JP Morgan. And if you're competing with Amazon, you're not going to do it. And so tremendous interest in what are the alternatives in every area, in musculoskeletal, in medications. Do you use PillPack? Do you use Roe? Do you use some of these other services that are providing dramatic innovation and drops in cost, taking all the structure out? I mean, company, and they're going direct to consumer, and they are convinced that they're going to build these systems totally outside of the existing infrastructure. And I'll tell you that given some of the early success, they are going to be successful. Now, these are enormous, so I don't expect the payers or PBMs or any of these parties to go away overnight, but they're going to have to be very, very innovative and not revert to the old models that they've been used to. They're going to have to step up, get measured on quality, get measured on improving care, and get measured on the customer experience. And those are the three metrics that are going to drive all success in the future. Do they like it? Do they love it? Do they love the experience? Is the care measurably better, and can you sustain that? And last but not least, does it, if it's not lower cost, will at least flatten the curve on cost versus a continuation of more and more money. So we see, the system is being challenged. It's being challenged not just externally, but internally as well. And it's going to be interesting.
Yeah. Well, I think health plans in particular, I'd be interested if you agree, there is an opportunity for them here, but they have to redefine themselves. That if health plans are honest with themselves, historically they have been in the administration business and the group purchasing business, right? It's outsourcing of a complex function for employers or for the government, and it is aggregating demand and trying to squeeze prices in some markets where they're able. They haven't fundamentally been about empowering consumers and engaging in their lives. And you kind of add that as a layer on top, and there's a lot of initiatives. But I think one of the things that's powerful about telehealth, or whatever we want to end up calling it, is it really breaks down the barriers to entry and makes healthcare a nationally competitive business. I can stand here and do a telehealth visit with anybody who's licensed in California, which is where I am, but those people sit in 50 states and in other countries and in other places. I can have Livongo if I'm here or if I'm across the country or on vacation. And I think health plans that look at that, instead of saying, well, this is the best I can get from the network here, or this is the only provider in this town. Now they can say, well, I'm just going to do that. I'm going to do that through telehealth. I'm going to do that through a new solution. I'm not just in the business of purchasing other people's care. I can shoot the gaps and I can make the experience better, but you got to start thinking about yourself differently. You do have to be willing to redefine yourself, and health plans and providers especially. And I think you have to view telehealth, digital empowerment, all of these concepts, not as an adjunct to your core business, both on the payer side and the provider side, but actually what you build for first. And you mentioned Amazon, Glenn, but I think about a lot of digital companies. Amazon is a technology company, but it's also a logistics company and an operations company. And there's a lot that has to surround the digital assets that they have, but they always start by thinking digital first. And then it's, what physical assets do I need? What logistics do I need to build around that? And I think that's a new mindset, both for health plans and providers as well. It's not to say, well, I've got this physical asset and how do I extend it through digital? It is, no, what am I building that's digital first? And then what physical capabilities do I need to create the kind of experience that's really possible? And that's pretty different. It's pretty different to say, I'm going to do a video visit because that provides 24/7 access when people don't come to my building, versus I'm going to be continuously engaged, and most of my patients or most of my members might not know where my building is. And that's going to be supplemented by a test kit that comes to their home and a prescription that gets delivered, and people who may come and help them, right? It reduces the need for transportation. It's the whole kind of ecosystem around that, but starts with the TeleView as the core. It's a very different way of doing it.
So we will start with the question, how will a significant shift towards telehealth impact the institution of MDs?
It's a good question. The challenge with these crystal ball questions is you're almost certainly not to be right. But I would broaden it a bit and say the long-term view is, if we move from episodic to continuous medicine, thinking about the MD's day as being built around the visit or built around, rounding, if you're somebody who's in the hospital, is a whole different view. I can imagine a world in which, to Glenn's point about Livongo, you have an MD who wakes up in the morning, who spends most of their time looking at their dashboard, not their appointment calendar, reaching out to people who might have turned red because of the continuous information that's being fed in, and then bringing in those handful of people, or going to those handful of people who really need an in-person encounter. I can also imagine that happening from a location that's pretty different than where they are today. It might be in a kind of group telehealth center. It might be their home, to my point about the physician who said to me that they can do it. I also think if we push way far out, anything that a physician does today that's largely a flow chart, as opposed to engaging with and empowering people, we should be able to replace. I think about simple prescriptions, for example, and you kind of go to first principles of, well, why do we have physicians write prescriptions? It's because we need a check on people, because there's an information asymmetry. If they don't know if the prescription's the right thing for them, it's what they need, if the side effects are going to hurt them, it's so on and so on. And so we have physicians write prescriptions. But for some of those simple ones, that could be replaced with, an online screener and maybe some sort of test, right? A pharmacogenetic test of some sort, and go right to prescribing. That doesn't mean you're getting rid of the physician, but what it means is that kind of low value, rote, flowchart based stuff that's really just about taking in patient information and rendering a judgment, you could start to replace. More near in, I think you probably see a redefinition of team-based care, particularly with telehealth. And it's an opportunity to save costs. There is not much of a role for a medical assistant in a telehealth visit. The idea of doing things like rooming, or even doing things like medication reconciliation, can be done digitally before a telehealth visit. And so you can get a lot more productivity out of it. So in short, I think, in the short term, you probably see more productivity, more cost-effective visits, more ability to work from anywhere, probably more ability to be part-time. In the long term, hopefully you see an evolution from being in a visit-based profession to being in an information-based profession.
All right, so the next question is, how will the D2C companies fit into a future of clinical care ecosystem, and what would it take for Livongo to be a direct consumer product?
Well, that's appropriate that this one came to me, I guess. It would have been interesting to have Sam answer that one. So as I've already said, the nice thing about Livongo is we have a direct relationship today with all of our members. We're interacting with them, we're talking with them, we're interacting digitally with them virtually every day if they're checking their weight or their blood pressure, maybe twice a week, not every day. If it's their blood sugar, it could be every day. And on mental health, it's in spurts, depending on what they need. So we're already interacting with them. We're also actually delivering them to their homes, things like test strips and other supplies. So what I would say is we're not that far from a direct to consumer. That really comes down to the economics, which is I don't think in the short term you'll see us running ads. But on the other hand, what we've done is we've used third parties to help us access large groups. So let's talk about the government. So with the Federal Employees Health Program, more than 5 million people receive information from the government saying Livongo is a covered benefit. If you talk about GEHC, GEHA rather, is another government program that covers about 2 million people. So all of those folks essentially see us as a solution that they can get through their existing provider. And then, as many of you know, we work with more than 1,000 of the largest corporations in the country, so large self-insured employers. And then our distribution, whether it be through health plans or others, we're always looking for people who can help make our services available very efficiently. But I think at some point in the future, we may well be direct to consumer. We know that when their companies are acquired or when they leave their companies and they don't want to lose their Livongo benefit, they come to us and we do offer the ability for them to get our services directly. So we have the capability. I think it's just a function of time and ease of access. But at the end of the day, we want to meet them wherever they are, make it easy for them to be healthier using Livongo services.
All right, next question. What needs to happen to be sure that limited resource disbursement populations are not left behind in the new ecosystem?
Yeah, I'm happy to start, and Glenn, you add on. I mean, the health inequities that exist in the United States are one of the great moral failings of the U.S. healthcare system, and we absolutely need to be careful that we don't further reinforce those inequities because of the digital divide that exists. In another part of my life, I'm on the board of a college, and we had to send students home post-COVID, and the number of students who didn't have a computer at home, didn't have Wi-Fi at home, right, weren't able to engage in the kind of remote learning that we were very proud to provide was really quite sobering. And we fortunately were able to provide Wi-Fi hotspots and all sorts of things to help them. But if you apply that to healthcare, there's a similar situation where, if we say that a solution requires Wi-Fi at home or requires a mobile phone that you pay the bill for or whatever, we've then got to make sure that those resources exist. And so, I think we shouldn't use that as an excuse to slow the expansion of telehealth, because frankly, providing somebody with broadband, with a mobile phone, with whatever they need is a relatively inexpensive thing to do where it's available, and we can design technologies so that they can use lower bandwidth. But we've got to think about the availability, particularly of broadband connectivity, as a social determinant of health. And just as we think about sending people transportation and spending money in the system to do that, we probably need to think about making sure they've got the infrastructure they need to benefit from everything we're providing in the same way.
Yeah, and I would second that. Look, we're in a conversation right now about racial inequities across the country at the same time we're dealing with COVID. And it actually is appropriate because COVID is a health crisis and it is disproportionately affecting African Americans and other minorities. They're twice as likely to be impacted in a negative way by COVID. That's a health inequity that we have to address. I would turn it a bit in the opposite direction. I'd say that digital actually presents us with the best way to take care of the entire population. Because if you think about it, whether it's a rural population, whether it's an inner city population, if we give them a Livongo device, it's a cellular connected device. They don't need bandwidth at home. They don't need a computer at home. We've given them a tool and they can get world-class care wherever they are, anywhere in the world today. And they can do that. Now, part of that care comes from getting real-time information. Part of it comes from getting digital coaching. Part of it comes from, if they're in trouble, the system will actually send out a notification to other people to say, hey, you're sitting in the other room, but you should know that your partner, who's only a room away, actually needs your help right now. And they might not even be able to tell you. So we can provide all that. Then if they have a cell phone, and most people have a cell phone, we can actually get on the phone with them instantly in 30 to 60 seconds, talk them through whatever their health issue is. Similarly, in behavioral health, where our My Strength product comes into play. That product, it's a digital front end, it's available digitally, but it also enables people to get care where otherwise they might not be able to talk to a licensed professional about whatever issues they have. So I think digital is the great equalizer. Now, what do we have to do? We have to make sure our federally qualified health centers are digitally equipped. We have to make sure that people in need get the digital connections. And there's some complexity to it, but we can solve that. That is the easiest issue to solve. And when we think about all of the money that we're spending, what we have to start to think about is it's important from an education standpoint, from a health standpoint, from an equity standpoint, maybe even in the future from a voting standpoint, that everybody in this country needs to be connected. That is going to become a key differentiator. So that is the ticket. You know, if you think about education, everybody can't go to a great school. In some areas, it's dangerous for young children to get to school. But if they have a computer at home and they have a connection, we open the whole world to them. If they have a computer at home and they can do remote monitoring or telehealth, they now have a world-class doctor that they can talk to, and she can provide care that they were never able to get to before because they didn't have the ability to go across town, but now they can talk to. So I think we have to look at the promise of what this could deliver and start to think of this as every building ought to be equipped and every location ought to be equipped. And that is as important for students as it is for every one of us for our health. So it is a reachable, doable thing. We don't have to invent anything new. There's no new research we have to do. We simply have to fund those dollars. And more than ever with the pandemic, more than ever with the discussion on racial inequalities, this ought to be top of the agenda.
Yeah.
All right, we've got time for just a couple more questions. So the next one is, what safeguards will there need to be for duplication and or fraud, and also privacy and security?
I can take that. You know, I believe that it's actually easier to detect fraud and duplication if you have a digital system than if you don't. Think about the old days, which are still the current days in some places. You go to an individual physician and he or she has your file and it's in a manila folder and it's in a file cabinet. And then you go to a different physician across the city. The chance of those two figuring out that you're getting the same medication or the same care is pretty much zero. Contrast that with an electronic system where we can simply run checks and to see where patients are, and to make sure that we're not giving drugs that, not only for fraud, but drugs that have terrible interactions that could kill someone. So we can do all that digitally. Now, we have to provide the same kind of privacy protections that we've provided in many other areas. And, can those systems be hacked? Yes, they can. Can people commit crimes? Yes, they can. But we have to build in the fundamental safeguards that we have in many other industries. It's interesting. We're willing to use a card for an ATM that is all our money, and we trust that. And then we move over to healthcare, and somehow we think we can't use the same system for sharing our information. And in 90% of the cases, healthcare, maybe 99, healthcare information is really boring. Unless you're a celebrity, or unless you have something that is really you're seriously concerned about. So we have to build in world-class safeguards, and we're doing that. All of the new digital providers are meeting standards, exceeding standards, everyone that I've seen. And every time we interact, when we interact with a large company, they check the security. When we interact with our health plan partners or our PBM partners, they check security. So everyone is focused on it. And I think we're going to get there. But there are always going to be exceptions to those rules. And the one other thing I'd say relative to interoperability is, look, this was a failing of the electronic health record, the electronic health record world. It should have been built in up front. It's been added to by folks like Epic who've refused to actually add interoperability as a core feature. And that, the government is going to need to step in and mandate it in a very direct way, because patients own their information. It ought to be easily accessible wherever they are. And that's our belief. It's our belief at Livongo, and it's our belief across the healthcare world.
Well, thank you, Glen and Sam, so much for taking the time to share all these insights with us. I know we're wrapping up here. Do you have either of you have any final thoughts you'd like to share?
I just say thank you to everybody, and especially Glen. Thank you to you, my friend. It's always inspiring and thought-provoking to have these conversations. I know there were probably a lot of questions we didn't get to, and a lot of things we said that people may disagree with. And I'd love to continue the conversation with anybody who's passionate. Feel free to shoot me a note. It's just sam.glick@oliverwyman.com. Would love to chat with anybody who's interested.
And Sam, thank you. It's always enlightening. I always learn when we have these discussions. I'm at Glen, Glen, at livongo.com. And I would say two things. One, we have some big challenges. And I wrote an essay today that's available in a variety of sources out on the internet. But what it talks about is, in the last 2 weeks, we showed how innovative we can be by launching private industry, putting us back into space in the United States. And if we can take that same innovation, that same drive, that same vision that we have for space, and redirect it to solving racial inequality, to solving our healthcare challenges. Those are easier to solve than sending a person into space. They're easier, but we have to have the resolve to do it. And the other thing I'd say is we have to stop talking about it. We have to start acting. And there's this philosopher named Ashley Brilliant, and she asked the question, why don't we get braver as we get older? We have to get braver. We have to lead. And so again, everyone on this, if you go out and you take action to say, we can do better, because we can, and we're going to do it together. So thank you, everyone. Really appreciate it.
Hear, hear. And I want to give a virtual round of applause for Elizabeth. Excellent job. Thank you for the illustration.
Yes.
It's been fun watching it as you do it. I do think you clearly believe Glenn is more handsome than I am, but I'll take it.
I'm just glad that you gave Sam eyes, because initially you put his head there and he had no eyes, and I was really worried I was gonna, and then you filled them in. So thank you, and you made me look much younger. So thank you very much. And I think again, we're all learning about Zoom. It's fun to use the technology to have notes. They're all accessible to you. So again, thanks very much, everyone. Have a great day. Have a great weekend. Really appreciate your participation.
Thank y'all.